we know that MSI, metastatic colorectal cancer, are a little bit particular because it's the prognosis and the chemo sensibility is a little bit less compared to the microsatellite stable disease. And it's also rational to use immuno-oncology and anti-PD-1 because MSI is with a lot of mutation, a lot of infiltration with lymphocytes, and with it's clear that it's very particular tumor with a lot of neoantigens and very high mutation tumor burden. And the reason the story began now 5 years ago with the first paper by the John Hopkins in US with incredible New England Journal of Medicine, and after we have a lot of data. We have a lot of trial with Pembro, with Nivo and ipilimumab, with good efficacy in MSI, but refractory patients. And it was necessary to have a phase 3, to have a labeling in first line, to have labeling in Europe. And KEYNOTE-177 is this trial. Yes, the design of the trial was very simple. It was a randomization, 1-to-1, pembrolizumab, 200 milligram every 3 weeks versus chemo, FOLFOX or FOLFIRI, plus or minus cetuximab and bevacizumab. 2 years of Pembro, therapy for chemo like Pembro, and we stop in case of toxicity or in case of progressive disease. The endpoint, the primary endpoint was a dual primary endpoint. It was progression-free survival and overall survival by blind independent review committee for the CT scanner, and it was evaluation by RECIST 1.1. Results are 3 good news for the patients. The first one is the progression-free survival is better in the pembrolizumab arm versus the chemo arm. It's 16.5 months in Pembro arm versus 8.2 months in the chemo arm. It's a hazard ratio 0.6 and a very significant p-value. It's really it's rare to see a so large difference between the 2 curves of PFS in metastatic colorectal cancer. It's this good PFS is also with after 24 months of follow-up, 48% of patients in Pembro arm are without progression and can stop the therapy. In the chemo arm, it's 90%, and for the majority of the patients in the chemo arm, patients had to continue other therapy except in case of surgery of metastasis. It is the first good news for the patients. The second good news is the toxicity profile, because the pembrolizumab, it is 200 milligram and it's well tolerated. It's the toxicity is we have 22% of grade 3/4 versus 66% for chemo, and it's really a huge difference. With Pembro, it is immune toxicity. With chemo, is the classical with nausea, vomiting, neutropenia, alopecia, neurotoxicity. But it's with Pembro, it's really manageable. We don't have toxic deaths. It was really the classical toxicity, easily manageable. And the third good news for the patient is the fact that the convenience of the therapy is very good for Pembro, because it is a 1-hour injection every three weeks, compared to chemo, really more complex with half day in out hospital, a pump of 5 FU, and all the the possible toxicities the day of the therapy with the chemo and the targeted therapy. The main conclusion is the fact that pembrolizumab provides clinically meaningful and statistically significant improvement in progression-free survival in MSI-H colorectal cancer, and should the new standard of care for these patients. The overall survival was the other primary endpoint of this trial. The steering committee asked you to wait. It's too early, not mature, and it is planned if 180 events occurred, or 1 year after the the PFS analysis. Probably it is for next year, and it's important to underline the fact that in this trial it's a crossover for pembo in the chemo arm, and the patient with progressive disease in the chemo arm will receive pembrolizumab or other immuno-oncology if it's out the trial. And at this time, we know that approximately 55% of the patients in the chemo arm received anti-PD-1 or anti-PD-L1, and for the interpretation of the overall survival, it will be important to take this point in consideration.